burns cost about $5.9 billion a year in direct property damage. And the leading cause of fire deaths is smoking. I think you won't know by now. I think smoking is very hazardous to your health. The skin has 3 layers: your dermis, your epidermis, your dermis, and your subcutaneous tissue, which is your fat, muscle, and bone. Your dermis contains your blood vessels, your nerves, your hair follicles, and your sweat glands. There are 3 types, or 4 types, depending, of your burns. You have your first degree or superficial burn. This is your lovely sunburn that you get when you go to Cedar Point. Does it hurt? Yes, a lot. Sometimes aspirin will help decrease that inflammation. Tylenol doesn't help so well because it's not an anti-inflammatory. You want an anti-inflammatory such as aspirin. Your second degree is where you may get a blister, but there's generally no permanent damage. There are 2 different types. You've got your superficial partial thickness, no blister, or your deep partial thickness, blister. That's the difference. Does it hurt? Yes, because your nerve endings are still there. Do not poke the blister. As long as the blister is intact, your skin as a barrier against infection is intact. Don't poke holes in it. It's there for a purpose. Third degree or full thickness burn is the worst. This needs a graft to repair, but the nice thing is with the area of a 3rd degree burn or full thickness burn, there's no pain because you have actually destroyed the nerve endings. But there's no one who has just 3rd degree burns because they're dead. So you have areas of 3rd degree surrounded by 2nd degree, surrounded by 1st degree. So burns are extremely painful. If you think about this pathologically, this diagram is showing different burn injuries where you've got the first one, your 1st degree partial thickness, where the skin is reddened, still intact. 2nd degree partial thickness, now you have blisters. And 3rd degree, you have charring. That tissue is dead. And this is the rule of 9s, which you need to know. So I would try and remember it if I were you. It's also in your textbook, but it helps in determining fluid resuscitation. And here's some pictures of burns. We have our superficial, then we have 2nd, and we have 3rd degree burns. The top one's an electrical burn caused by chewing through an electrical cord. Weird. The other one's on the mouth, probably from a cigarette that got too close. This is a burn from hot water on a child. That's why it's really important you keep your handles turned in on your stoves. Okay, patho review. Initially, you'll have the hypovolemic stage. This lasts 48 to 72 hours. Now we're talking burns that are 2nd or 3rd degree, not just your superficial burns, but these are the partial thickness and worse. Where you'll have your hypovolemic stage that lasts 48 to 72 hours. During this time, fluid will escape into the interstitial spaces because initially you're going to have increased capillary permeability and vasodilatation. So the 2 together allow fluid to go into your interstitial spaces, but it also allows the large protein molecules to go into the interstitial spaces. And protein will pull more fluid with it, and so does sodium. It'll pour more fluid with it. And zinc will also go into that interstitial space, and so that's where you get your blisters and the edema that occurs. So this will cause a negative nitrogen balance because it's lost in the kidney due to catabolism of your proteins. So you're breaking down your proteins because you need that. Your BMR has been increased, your basal metabolic rate, but you're going to have a negative nitrogen balance. Intravascularly, you're going to have a low protein level, hypoproteinemia, so low protein in the blood, because it's all going interstitial. You're going to have that negative nitrogen balance, as I said, because it's being lost through the kidney, nitrogen. and you're breaking down more protein. And you're going to have hyperkalemia because you're going to have lots of cells that have been damaged, releasing their intracellular potassium into the intravascular system. And you're going to have red blood cells that have been lost. So this hyperkalemia can cause dysrhythmias like heart block or ventricular fibrillation. You're going to have an increase in your hematocrit because you're going to be dehydrated. Your plasma is escaping third space. It's going to the site of the burn. And you're going to activate that stress response in an attempt to save your sodium, but most of it's still lost in the interstitial spaces. And so you're going to end up with metabolic acidosis. You need to understand that and what's happening there. The diuretic stage starts 48 to 72 hours after the burn, as the capillary membrane integrity returns to normal and fluid starts to shift back into the intravascular space. So you're going to have an increase in renal blood flow, which will increase your urinary output. That's why it's called the diuretic phase. And that's going to lower your hematocrit, but it's also going to decrease your electrolytes. Now, your sodium is already lost, and it's going to lower even further. Because you're going to lose sodium in the urine to help get rid of some of this water, and that's going to make the metabolic acidosis worse. You're going to have potassium shifting back into the cells, but it's also excreted in the urine, and now you have to deal with low potassium levels. And protein is still being lost into that open wound, so you're still losing some fluid there, and you're still in a negative nitrogen balance due to the tissue destruction, the protein loss, and the stress response. And anemia, because of the loss of the red blood cells, still exists because it takes about 6 weeks to correct that anemia. Complications from a burn are contractures, because it heals in the wrong place, in a bent area, and you get eschar there, and you need to get rid of that. Compartment syndrome occurs because of the swelling, the edema in the area. So you burn to the upper thigh, you're going to have edema there. That's going to decrease the blood supply to your lower leg. The lower foot is going to be pale, cool. You're going to have pallor, paresthesias, which are numbness and tingling. Temperature is going to drop. Let's see, there's 6 P's, and I'm trying to remember them. Oh, pain, pallor, pain, paresthesias, poikilothermy, which is your change in your temperature. I'm missing 2. Oh well, make sure you know what they are, because I don't have them written down. Infection, always a risk when you break that skin barrier. That's why you do not want to get rid of your blisters. So infection is a major risk and a major concern, because oftentimes it's the cause of death. Malnutrition. At the time following a burn, you need at least twice the usual number of calories, and you need 2 to 3 times the recommended daily allowance of your minerals and your vitamins. It's really important. Some possible nursing diagnoses are acute pain. Yeah, it hurts. A potential for infection, ineffective airway clearance, body image disturbance, major concern, anxiety, nutrition less than body requirements, decreased physical mobility, altered self-concept, and there's grieving. There's a whole bunch more. Think about them. Treatment. Fluid resuscitation is important. Now, the consensus formula says you use 2 to 4 milliliters per kilo to replace. For the Parkland formula, you use 4 milliliters. And the Parkland formula is used most of the time. Sometimes, depends on the degree of the burn, they may go with the consensus, where you use a little bit less. But 4 milliliters times the weight in kilograms times the percent of the body surface area burned in a whole number, so not as a percentage. So that in the first 8 hours, you're going to give half that total amount, calculated from the time of the burn. So say you were burned at 4 a.m. You got into ER and started therapy at that time, and you had burned, we'll make this easy for my arithmetic since I'm doing it in my head, 10% of your body. So, and you weigh 100 kilos. So 4 times 100 is 400, times 10 is 4,000, right? And so half of that you'll give in the first 8 hours, so that means 2,000 you have to give from the time of the burn for the first 8 hours. So that means for the next 6 hours you're going to give 2,000 milliliters, and so that's 333 milliliters an hour. You will be infusing that. And then the remainder, the other 2,000, you'll give over the next 16 hours. So you'll give, you do the math. But the thing to remember is the percentage of body surface area as a whole number that you use. You want to prevent complications such as compartment syndrome because of the degree of edema that collects around the tissues from the burn, as I mentioned, or contractures. And you prevent the contractures by daily cleansing and using some force there, and debridement to remove that eschar, because that eschar can also prevent the skin from stretching, and you want to get rid of that. Chilling is a complication because many of these wounds heal open to the air without being covered by a dressing, and that puts them at greater risk for infection, and that's why you oftentimes are on antibiotics. Pain management is very, very important. They should be getting continuous PCA with morphine and or Versed, particularly with wound therapy. Now, the nice thing about Versed is they may not remember everything you're doing, but morphine is really important also. They will not become addicted. To prevent that infection, you're going to use Silvadene, which is a white cream. It is bactericidal. It develops a slimy gray appearance even with negative cultures. Your sulfamylon is bacteriostatic. It penetrates through the eschar, but it is very painful with that application. And they have to be in reverse isolation, a private room. You want to protect them from infection. It's not that you are protecting other people from them. You're protecting them from the infection. Skin graft, you will cover the wound. It will speed the healing. It will prevent contractures, and it will shorten their convalescence. An autograft is from themselves. A homograft is from a cadaver. A heterograft is from another species, usually pig, because their skin is very, very soft. And an aplograft is one that's grown in a lab and combined with the patient's skin, and then genetically re-engineered and grows really, really quickly. So there is not really any risk of rejection. The nice thing following 9/11 is the company that made this sent all of everything that they had to the to New York, so that they would have lots of material for grafting, because there were many burns that occurred after that. This finishes this lecture.